So PJK is a tough problem, and as we go through things and see cases, we learn sort of anecdotally what works and what doesn't work, and I figure I'd give some ideas about my experience with PJK and some overview of incidence in literature. So these are my disclosures. So it's of key importance in deformity surgery, and the main reason is because it's a common cause of return trips to the operating room, a common potential cause of poor outcomes, and so it's something that we got to pay attention to because we're going to see it. And so if we can identify ways to predict it or reduce the incidence, we'll be better off. So there are various different definitions. There's PJK and then PJF. So PJK is essentially a radiographic measure when you have greater than 5 degrees of segmental kyphosis above a fusion. Proximal junctional failure is 10 degrees of post-operative increase in kyphosis at the top of the construct with an association of either a fracture of the vertebral body, a disruption of the ligamentous complex at the top, or a pullout of the hardware at the very top of the construct. So these are the you may hear PJK, PJF. These are the definitions. So the incidence is varied. It depends on the series that you evaluate, but you can see some numbers that are quite honest. As high as 60%. Incidence of PJK. So definitely a sizable number there, so if you really carefully scrutinize your post-op X-rays, you'll see an element of kyphosis a lot of the time, whether or not it is regarded as a complication or whether it's regarded as a radiographic finding is debatable. Fortunately, a lot of PJK may just simply be a radiographic finding and may not necessarily be symptomatic. It's something that's there. It may not necessarily be operative. It may just be something that you observe and follow over time. So to identify criteria for revision surgery, Bob Hart, who's on faculty here, has evaluated many patients from the large deformity database and identified that 47% of the patients who had failure ended up requiring revision surgery within 6 months of the index operation. So if you do have proximal junctional failure, beware of the imminent need for potential surgery. So pay attention to your post-op X-rays and look carefully to what degree there is a kyphosis that's developed, or whether or not there's an associated disruption of the ligamentous complex at the top or pullout at the top. Be cognizant of the fact that surgical revision is imminent. So to add to that, there is a heart kyphosis severity scale, which is depicted here in this table, and the higher scores on this scale are predictive of the higher potential need for revision surgery, and so this can be calculated and determined. So we'll go through a couple different cases. This was a referral from a local community hospital. This is a 68-year-old female with osteopenia who had an L2 to S1 fusion. This was a PJF situation. You can see the top screws have pulled out. A calculation of her pelvic incidence and overall lumbar lordosis and parameters revealed a mismatch. And so that's one of the precursors to a possible prediction of a PJK or PJF event, is when the index surgery did not allow for an adequate correction of the balance, or when the patient has a history of osteopenia. Those two together can cause a significant problem. So you can see how the top of the construct pulled out. You can also appreciate how the patient reduces partially when she lays down. Again, a finding that we've discussed before, that you can utilize the sagittal cuts of a CT scan as kind of like a supine X-ray to evaluate what the lordosis corrects to when the patient's laying down. So this is a case where vertebral augmentation I found to be handy at the very top of the construct, combined with a resection of the pedicle at L4 and an interbody fusion, and doing this restored her lumbar lordosis. You can appreciate the correction and the reestablishment of the equity between the pelvic incidence and the lumbar lordosis. And this was a 4-year follow-up demonstrating a satisfactory restoration of her sagittal axis. You can see cement augmentation at the very top, cement augmentation at the area above the top screw, and durability and no further PJK. So that was one potential success story of a patient who had PJF and revision surgery and no subsequent problems. So the lesson learned from there is a patient with osteopenia. You got to make sure that you examine the correction goals carefully and try to get a good correction, utilizing hardware that may be amenable to augmentation, and to obtain better fixation, and to pay attention to your pelvic parameters to optimize the correction. This is a different scenario. This is a patient, again, with poor bone quality, a history of myasthenia gravis. He has had a previous L23 instrumented fusion, and several years prior to that, he had an uninstrumented fusion distal to L3. So his construct was an L2, or his situation was an L2 to S1 fusion, but he had only had instrumentation at L23. Of note was the fact that he had a pelvic incidence of about 45. So this patient did not need a tremendous amount of correction. This is a case that I did in 2013, and I looked at the L4 vertebral body and thought he would be an ideal candidate, given he had a fixed sagittal plane deformity. Did a PSO at L4, and you can see that we got a substantial correction of the lumbar lordosis. And the sagittal cut CT over there shows that he had a total restoration of his sagittal balance, and was quite happy with the post-op films until this developed. So he developed yet another PJK at T10. So I thought to myself, okay, well, this was a failure. He was having substantial difficulty. Did another PSO at that level and extended him up a year later, and then I kept chasing my tail on this. So the lesson learned from this was the original pelvic parameter measurement. the pelvic incidence was around 45. The correction, the final lordosis was around 53. So this was an overcorrection. So this patient kept on developing PJK over and over and over again because his PSO was an overcorrection. And so that's something to be cognizant of. And I've learned from this. When there is indeed an overcorrection, sometimes I go back and do a osteotomy to undo the overcorrection and introduce kyphosis into the area of excessive lordosis. And that I've found has arrested the continuous PJKs in certain circumstances. So potential causes and contributing factors, it all is patient-specific, but various factors are often revolve around the fact that patients have poor bone quality. And if there is poor bone quality and you have very rigid fixation, those two are quite predisposing to the development of PJK as well, even when you have a perfectly matched correction. So you got to look at various other aspects: age, smoking history, other comorbidities such as Parkinson's disease. What is the actual fundamental problem and history of the patient. So these patients are at higher risk of developing PJK. It's a bimodal problem. It either occurs very rapidly after surgery or within 18 months after surgery. And so that's one of the other things to look out for. You're either going to see it early on or you're going to see it about over a year afterwards. There is a bimodal distribution to this. So to avoid PJK, again, it requires careful preoperative planning. It requires you to be cognizant of the fact that not everyone needs to be corrected to the standard pelvic incidence equals lumbar lordosis plus or minus 10 degrees. If you have an older patient and you have patients with less good bone quality, you may consider using various different formulas that have been published to suggest that you don't want it, your correction goals need to be modified based on the patient's overall condition and age. So not everyone with a pelvic incidence and lumbar lordosis mismatch needs to be corrected to the same extent. It depends on what your age group is. So there's various literature that either supports or negates the utility of augmentation at the top of the construct. I find that if the patient has poor bone quality, it is often of benefit. And some of my patients who've done very well, in whom I predicted the high risk of PJK, have not developed PJK when I implement this technique. And with the advent of fenestrated screws, I think it's quite easy and efficient to add cement to the top of the construct. The other consideration is utilizing stabilizing entities at the top of the construct, such as Merceline tape. This is a paper from Justin Kleinberg, one of my colleagues. Eric Kleinberg. Eric was actually one of my co-medical students. We both graduated from the University of Maryland and were there at the same time in medical school. It's nice to follow his success with his orthopedic spine practice. And he published this article not too long ago demonstrating a reduced incidence of PJK utilizing Mersaline tape. This figure shows the technique, which is, I like it because it's a low-cost technique. You can see that the Mersaline tape gets placed through the top UIV+1 spinous process, and then it's tied to the crosslink. And what you can do is distract the crosslink caudally to further tighten the Mersaline tape, and that actually can add tension to that Mersaline tape, and it's a sort of like a nice sort of budget type of stabilizing entity, and seem to result in fewer incidences of PJK in his series. You can see that these graphs demonstrate a reduction in the proximal junctional angle that was measured, as well as a reduced likelihood of requiring revision surgery in that bottom graph. That's a Kaplan-Meier graph showing that the augmented group within the Mersaline tape group had less need for revision. So just one final case, a patient with an L2 to S1 fusion who required an extension to T11. He was one of those in that bimodal distribution that I described earlier. This was an early PJK/PJF. You can see that's his immediate post-op X-ray, but he quickly developed a lot of pain at the top of the construct with some about 10 degrees of kyphosis up at the very top. It was pretty symptomatic. This patient had osteopenia. It turns out that he had an undiagnosed parathyroid problem, and so we got that addressed. I wouldn't have expected this healthy 61-year-old gentleman to have osteopenia, but his bone quality just didn't feel normal, and this is a reflection upon that. This is a patient who required a 3-column osteotomy with extension up to the T8 level, or no, T9 level, and then I did a cement augmentation above that, and he's been good ever since. So again, a reminder that the Spine Summit is in February 2024 in Las Vegas. And any questions for me? Yes.
Just a quick question. How often are you? Oh, sorry. How often are you using Forteo or bisphosphonates or things like that for patients that you identify preoperatively who have significant osteopenia?
Yeah, so that's a good question. You know, I find that if that's kind of part of my preoperative conservative treatment screening, you know how patients are required to go through all conservative measures possible to optimize their post-op outcomes. And if they are identified to have osteopenia, I do recommend them seeing an endocrinologist to get Forteo. And I like to give Forteo for 6 months and then have them come in, get the surgery, and continue the Forteo for 3 months afterwards, because Forteo not only is a benefit to build up your bone density, but it also increases fusion.
Microphone's coming. What are your thresholds for considering cement augmentation to UIV+1, particularly?
So I think it's patient-specific, but if I worry about the patient, first of all, if the patient comes in with a PJK, I'm more likely to recommend it as a mechanism to avoid yet another PJK after the treatment of the first PJK. There is a risk with the cement augmentation. You know, I probably should have added this one example of a patient that I recently treated a patient who was referred to me with a pseudoarthrosis from another institution, and we did the correction of the rod fractures, but he also had a PJK at the very top. And we decided not to treat that and just fix the rod fractures because the majority of his pain was at the base of his spine, and followed him over the years. And the top was becoming more and more symptomatic. And so we finally took him about like 8 years later to fix this about last week or 2 weeks ago. And because he had PJK, I did the augmentation UIV plus UIV plus 1, and this patient developed a moderate-sized embolus of the cement into the pulmonary artery, and so it's not without risk. So it's you got to be cognizant of the fact that you do impose risk, and even when you try to do it as carefully as you can, not sort of just jamming all of the cement in there like super quickly. Certain cements have different characteristics. Some harden very quickly, and you're in a rush to get it to go in. Some harden more gradually, and you can wait for it to harden to the point where it's still usable, and I think it would be less likely for it to embolize. So it's a balance.
One more question, then we'll go on to Dr. Ami Abdul-Jabbar. How long do you get to know a patient with a not neurologically, not structurally critical adult spinal deformity before you actually operate on them? In other words, do you do a prehab process? I want to tag onto the Forteo question. How long should we kind of really work with patients before we commit them to surgery?
Yeah, it's at the very least, it depends on how disabled they are to some degree and whether or not they have any neurological deficits. But in the absence of neurological deficit and it's purely pain, I would say I try as much as possible to get them preoperatively conditioned. With aquatherapy is often a recommendation. So I would say at least 3 to 6 months.
I can't stress that enough. I think this prehabilitation process is much overlooked, and so many things that we do are really a problem. A walker, a four-wheeled walker, is terrible, absolutely horrible. Why aren't we using more tall walkers? Why are we allowing patients to walk around with canes when we have trekking poles, stuff like that? So I really think that this is something where we can all really be far more engaged and, again, show the way and not trust rehab doctors or no dissing to them or PTs. I think this is us and on us to kind of lead the way there. Any thoughts on how we can engage it more, make it more generalizable? Again, checklist medicine, hate to use that term again, but be a little bit more organized in our approach?
Yeah, it's a good question. I mean, the AANS and the CNS, we write guidelines for various different surgical procedures, and I mean, maybe there should be a prehab guideline, document written for deformity patients where the patient's not imminently at risk of neurological compromise, and you could potentially advocate for that in that group.
Great. Well, thank you, Charlie. Great lecture.
Thank you.